Hello friends, welcome to Future Doctor. I am Shivam Chaudhary and today we will study about hepatitis. So about hepatitis. So as we all know that the primary site of hepatitis is liver. Now we will study some basic information of all the types of hepatitis virus. So first before studying about the family we will write a mnemonic to remember to make it easy. Private, hospital, favor, rich, clients. So from private we will remember picorna virus. Its old name was Antrovin 72. From hospital we will remember Hepatitis virus, and from fever we will remember flavivirus. And from rich, so it is rich means it should be defective virus. So it is defective virus, so it is not having any family. And from clients we will remember calcivirus. So right now about the genome. So as we can see that we are having DNA hepatinovirus in hepatitis B virus. So only this will have DNA genome. The rest of the others will be having RNA genome. Yeah. And now about the envelope. The hepatitis A is not having any kind of envelope, and hepatitis E is also not having any kind of envelope. And rest of the other viruses are having envelope will be present in rest of the viruses. So about the cultivation is possible in only in hepatitis A virus, and it is not possible in all the other viruses. And vaccine is available for hepatitis A virus, hepatitis B virus, and hepatitis E virus. And for hepatitis C and hepatitis D virus, there is no vaccine available yet. And there is one more special thing we need to study, that for hepatitis E virus, its vaccine is only available in China. No other country is authorized. And for last mode of infection, so for hepatitis A virus, the mode of infection will be fecal-oral route. It will be transmitted through fecal-oral route for hepatitis A virus, and also for the hepatitis E virus. And for rest of the all viruses, hepatitis B, C, and D viruses, it can be transmitted through the blood. All the ways from which it can be transmitted, like droplet or any kind of factor like mosquito or direct contact, it can be transmitted. So right now we will study about the hepatitis A virus. So hepatitis A virus, first of all, it is very small in size, 27 nanometer, and about the mode of infection, as we studied before, it is having fecal-oral route, and there is no chronic or carrier state. And in hepatitis A virus, there is no risk of hepatic cellular carcinoma. Also, and it appears in feces 2 weeks before onset of symptoms. And what's its pathogenesis? First, it affects our gut. From gut, it infects our blood, and from blood it goes to our liver, and through liver it infects our hepatocytes. Yeah. And now what's in its incubation period? Its incubation period is 3 to 4 weeks. So in most cases, it will resolve in 1 to 3 weeks, and it is an infectious virus, infectious hepatitis, and there will be some entry pathogen. It can be caused by contaminated water or shellfish. So now about its clinical features. So there will be fever, anorexia, nausea, vomiting, and jaundice can be seen. And the patient's transaminase level will be raised. Dark urine will be there, and pale faces will be there. As I said before, that most cases resolve in 1 to 3 weeks. So right now, what is diagnosis? So IgM will be detected by ELISA test, and it appear at time of onset of jaundice, and after 2 to 4 weeks IgM will be replaced by IgG antibody after 2 to 4 weeks. And second one, IgG, there will be 4 folds or more than 4 folds will be there in IgG antibody. We can see by ELISA test, and there will be visualization of viral particle in feces also, and we can do culture of feces. Fifth one, there is no antiviral available, and but vaccine is available. So something more we can write down. So for hepatitis A virus infection, it can be rare. It can be rarely transmitted by sexual intercourse by homosexual men, and rarely by blood transfusion also. So now we will study about hepatitis B virus. So as we studied before, that it is having DNA genome. So it is a DNA virus, and it is having 2 linear strands of DNA. So first one is complete strand, or we can see minus strand, and another is incomplete strand or plus strand. So there will be 2 linear strand, and DNA polymerase has two activities. First, there can be DNA dependent DNA polymerase, or RNA dependent or reverse transcriptase. So right now we will study about its genome. Genome has gene. It is now having 4 genes. So P stands for polymerase enzyme. C stands for C antigen, means core antigen, and E antigen. E stands for envelope antigen. And for S, there will be HPS antigen, surface or Australia antigen. And about X, there will be HBX protein. It helps in viral transmission, helps in carcinogenesis, and it inactivates P53 gene. Now about mode of transmission. So from blood, or it can be transmitted through blood or any kind of product also, or it can be transmitted through sexual intercourse or cutaneous needle stick injury. NSI. It is an intravenous drug abuse, and there will be risk will be 30%. So there is a note that NSI for HIV there is risk of 0.3%, but for HCV there is risk of 3%. Yeah. And for mother to child transmission from mother to child, it can occur perinatal during birth. Here one more thing, that transplacental transmission is very rare, and no evidence of transmission of infection during breastfeeding will be there. Now about transmission. The transmission depends on HBE antigen. So it can be of two types. So there can be a carrier mother who are HBE antigen positive, and a carrier mother who are HBE antigen negative but anti-HBE positive. Anti-HBE is present. So in the carrier mother who is HBE antigen positive, there will be more than 90% cases that mother transmit virus to child. And in the carrier mother who is HBE antigen negative but anti-HBE is positive, so there will be 10 to 15% cases in which mother will transmit virus to child. For HBE antigen, it indicates high infectivity, and anti-HBE antigen, it indicates low infectivity. And HBC antigen means core antigen associated with nucleocapsid of virus and does not appear in serum. And about HBE antigen, it is an expressive antigen, expressed, and it appears in serum. About the carrier of hepatitis B virus. So any person who harbor HBs antigen in serum of more than or equal to 6 months will be the carrier of the hepatitis B virus. And in whole world there is more than 350 million carrier present in the world. So there will be two types of carrier. simple carrier or super carrier. In simple carrier, there will be HBS antigen positive, HBE antigen negative, and decreased DNA polymerase. But in super carrier, there will be HBS antigen positive, HBE antigen positive, and increased DNA polymerase, and there will be increased transaminase. But with time, many super carrier become simple carrier. So now we will study about serology of hepatitis B virus. So first, there will be HBS antigen will be there. It is the first serological marker appear in serum, and it appear before onset of clinical features and just increase in transaminase. And disappear 1 to 2 months after onset of jaundice, and it can be rarely persist beyond 6 months. Then comes our second serological marker. It is HBC antigen, or we can say core antigen. Yeah, it is present on nucleocapsid, and it does not appear in serum. And in hepatocytes, it can be detected by IHC, immunohistochemistry staining. Immunohistochemistry staining, it can be detected. And then here comes HBE antigen. It appear in serum either concurrently with HBS antigen or shortly after HBS antigen, and it indicates active intrahepatic viral replication and increased infectivity. About the qualitative marker, of viral replication, and it is measured for following up a patient of hepatitis B infection. Here comes the fourth serological marker. It is anti-HBC antibody. It appears in serum 1 to 2 weeks after appearance of HBS antigen, and in anti-HBC antibody IgM anti-HBC, it will be there in acute infection, and IgG anti-HBC, it will be there in past or chronic infection. So here comes our fifth serological marker. It is anti-HBs. It is a protective antibody, and it is the only marker which is present in vaccinated people, and it appears in the serum after the disappearance of HBs antigen. So now only two more serological markers are remaining. The sixth one will be anti-HBe. It indicates, as I told you, low infectivity. And seventh one, it is DNA polymerase. It is a quantitative marker of viral replication. So now we will study about its treatment. So there is no drug to give in acute phase, but in chronic phase the DOC will be entecavir and tenofovir, and we can give pegylated interferon alpha can be used. Pegylated interferon alpha, it can be used. And there is some other drugs also which can be used. These are lamivudine and adipofir. And about its vaccine, there are some vaccines available, recombinant vaccines. HBs antigen, it will be grown in yeast cell via recombinant DNA technology. So there will be Angerix B and Recombivax H. One more vaccine is there, Hepatitis B. These vaccines, these are given to first to the health care personnel and the travelers who are going to the endemic countries, and it can be given to the IV drug abuser and to the frequent STD patients. Frequent STDs. So now hepatitis B virus is completed, and now we will study hepatitis C virus. So as we have studied that there is no vaccine available, and it shows antigenic variation, the genes which encode for one of the protein which undergoes frequent mutation. And it leads to a number of subspecies which will be genetic hypervariable states. And this subspecies will be known as quasi-species. And about its family, as we studied before, it is a member of flavivirus, and it causes chronic hepatitis, hepatic cell carcinoma, and cirrhosis. And if patient of hepatitis C, there will be alcoholism will be there, then there will be increased risk of cellular carcinoma because of hepatitis C virus. And most of infection are asymptomatic, and even when symptoms occur, they are similar to acute hepatitis A virus or hepatitis B virus infection, but they are milder than them. And how about extrahepatic manifestation of hepatitis C virus? So V stands for vasculitis, P stands for purpura, A stands for arthralgia, and M stands for MPGN, membrane proliferative glomerulonephritis, MPGN, membrane proliferative glomerulonephritis. And about hepatitis C virus, it is potent cause of cryoglobulinemia, and for its diagnosis we can see IgM anti-HCV. It can be detected by ELISA test, and there is a gold standard RT-PCR we can do. And for hepatitis C virus, there is 6 genotypes. It will be 1A, 1B, 2A, 2B, 2C, 3A, 3B, 4, 5, and 6. 1 is having 2 types, 2 is also having 3, 3 is also having 2 types. So now about mode of transfusion. So it can be transmitted through blood or any product. There will be blood transfusion can be there, or NSI, needle stick injury, or it can be through the any IV drug abuser, or sexual intercourse. Sexual intercourse, it is rare but possible. And from mother to child transmission, it is also possible. So now about its treatment. For acute phase, we will give pegylated interferon alpha, can be used, and in chronic phase we give a PPR, pegylated interferon alpha plus protease inhibitor plus ribavirin. So here goes PPR. So there is one more point I want to share with you, that risk of perinatal transmission of hepatitis virus. In hepatitis A virus, in hepatitis A virus, the risk of perinatal transmission of hepatitis virus is not possible, but in hepatitis B virus it is possible because it is a pod virus. And in hepatitis C virus it may be possible, it may be transmitted or it may not be, and in hepatitis D virus it will be definitely transmitted. And hepatitis E virus also it is not possible. So hepatitis C virus is completed. Now we will study about hepatitis D virus. So as we studied before, it is not having any family, it is a defective virus, it is a delta agent. It depends on hepatitis B virus for its multiplication. It does not have genes for envelope. And there is DNA particle of hepatitis B virus. It will be 42 nanometer in size, and mode of infection will be sexual intercourse or blood and product transfusion or by clarinet. So there is two types of infection: co-infection and super infection. So a patient will be simultaneously gets infected with both hepatitis B virus and hepatitis D virus. But a person who is already infected with hepatitis B virus gets new infection due to hepatitis D virus. And co-infection, it is less severe, it is more severe. Less chance of fulminant, and in super infection there will be more chance of fulminant and hepatitis and hepatic cellular carcinoma also. For the diagnosis of co-infection, we can check IgM anti-HBC plus IgM anti-HDV. But for super infection, we can check IgG anti-HBC plus IgM anti-HDV. For the treatment, you pegylated interferon alpha. about the vaccine. There is no vaccine available yet. Vaccination with hepatitis B virus vaccines can provide protection against hepatitis B virus also. So now hepatitis B virus is completed and we will start hepatitis E virus. It is an enteric or endemic virus, and mode of infection will be fecal-oral route, and no chronic or carrier state is available. Hepatitis B virus, and no risk of hepatic cellular carcinoma is also there. And about its clinical feature, they are similar to hepatitis A virus infection, which are fever, anorexia, nausea, vomiting, and jaundice. And about it, its case fertility rate, CFR case fertility rate, is 1 to 2%, but in pregnant ladies it is 10 to 20%. And in hepatitis E virus there can be intense pruritus can be there. It will be cholestasis. It is a bile obstruction. I will write it here, bile obstruction. And for diagnosis, we will check IgM anti-HEV and more prevalent. It is more prevalent in developing countries. And no vaccines are available except China. And there is no antivirals also available. So here our hepatitis is over. Thank you so much.